few times. We work together on a project for my employer, and they have a lot of resources that we have taken advantage of, and that relationship continues to grow. Just a quick introduction about myself. I've been in healthcare for about 20 years. I started as a medical coder biller, so that's why reference data matters to me. It started a long time ago. I did an MBA from a local school, and then I did a doctorate in healthcare administration recently. And I've worked in systems and EMR transition to meaningful use. I've done analytics. I've done audit. Now I'm doing process improvement and data governance for my organization. And so we have a couple of fun use cases that I'm going to share with you. And Cheryl, want to give your background a little?
Sure. I'm Cheryl Mason. I work for Wolters Kluwer Health Language, and as such, I run a team of data analysts and informaticists in helping clients like Shannan and across the healthcare spectrum with their data governance and reference data management systems, data normalization, basically extracting value out of their data. So very happy to be presenting this again today, and just really excited to see all of you here.
So we'll talk today. Let's see. Let me get this going. Okay, there's just, headshots, but you know what we look like already, so. It's advancing on that one, but not on this one.
Yeah.
Okay, that's fine. As long as it's advancing, we don't care. Just
There's the agenda.
Yeah, and here's the agenda. So today we will talk about addressing healthcare's data challenge. I'm going to come around here because it's not showing on my screen. The importance of establishing streamlined data governance, which are both of my use cases and a couple others I think that Cheryl has to share. Key tenets of managing reference data and use case examples proving the value. All right.
Do you want to talk about the CMS and ONC rulings
yeah,
before we get started?
So my slides are not advancing, so I can't see my notes, but I know what, I'm intimate with this because of the proposed rules for CMS and ONC. So, the exchange of health information it's exploded since 2011, and the HITECH Act and EMR and meaningful use, and there's so many data tools. We don't really have good standards, as you all know, nationally for codifying that data, exchanging that data. So the ONC and the CMS both came out with proposed legislation for patient access and information blocking. It brings the payer, I'm in the payer space, I work for Blue Cross Blue Shield of Tennessee, and this brings in the payer health plan organizations into the release of information area to a degree that we have never been. So we're working to ensure that we have that governance and validity of that data because it's for the continuum of care for our members. And so this is kind of new for the payer world. I've been doing this for a long time, so I'm involved in a couple of really cool use cases. But the FHIR-based APIs that will be required, we can do that. We can do that through Blue Button. We have some concerns about releasing some of the information. We don't really have, there's conflicting guidance between Part 2 substance abuse type records versus HIPAA, what's going to be allowed. There's malalignment there, so some of this other proposed legislation is kind of trying to address that so that we can all release the same kind of data to care for our members. With the APIs, the FHIR-based APIs, some of that will be fairly easy to make those transactions, but the validity of that data and where it's sourced from, that's going to be a little more difficult to identify and govern. We think we're getting a handle on it from, I guess, maybe taking bites of the elephant in the room just a bite at a time. Cheryl's going to talk a lot about the importance of how we handle this reference data and how you identify where it comes from, and then we'll get to some use cases.
Awesome, thank you. So how many people do we have here in this room that are in healthcare? Almost everybody, not surprising. I'm really glad to see that healthcare has been invited to the table today. I learned, yesterday, that this is the first time healthcare has been at this conference. So really, really important topics in healthcare today, the data and what do we do with it. This slide is really, to me, it's an impactful, powerful slide. I've been in healthcare since 1970-something. We won't get into that in too much detail. But historically, we've had claims data. And we've had claims data since sometime in the 60s when we started exchanging information about the services that we were doing in healthcare. And Medicare came on board to start paying physicians for those services. It was adequate for the time, and it served a purpose. It still serves a purpose. It serves a good purpose. Since the time of CPT, we've added HCPCS to the mix. We've got ICD-9, and more recently, we've transitioned to ICD-10. We also have medication information and NDCs that we exchange for claims data. Laboratory claims, I don't even know how those are filed, to be honest with you, but likely with LOINC. And this information is good. It really helps set the foundation for the financial health of the healthcare system. It's information necessary for providers to get paid for their services, for payers to understand what those services are and make sure that they're meeting the needs of their members through things like medical policies, right? It's adequate, it is incomplete data, and it is sometimes inaccurate, because if we're really honest about it, what's on the claim is what is necessary for payment, not necessarily everything about a patient and what was done and why it was done. Nonetheless, we can still do some things with it. It's essentially created for morbidity and mortality reporting, ICD-10 at least, across the world. And everybody across the world reports to the World Health Organization their ICD-10 information. Lots of good epidemiologic, yeah. We can identify where things like the bird flu originated. We can look at HIV incidences across the world. We can identify a high population of diabetic patients in the Greater Nashville area. We can say where heart disease is most prevalent on the western slope of Colorado, where I'm from. Lots of good basic information, but we don't get to the depths of clinical care, and we can't identify gaps in care. We can't identify care management programs and really inform any solid secondary clinical use cases. With the emergence of meaningful use back in the early 2000s, how many in here are familiar with meaningful use? A few. Okay, so meaningful use was created, it was an infusion of money into the healthcare system to implement electronic medical records. The ONC was created at that time to really monitor and manage that program. And it's been successful. Initially, meaningful use stage 1, you had to meet the requirement of being able to exchange information about a laboratory test in LOINC. And please stop me if I use acronyms that you don't know or understand, and I'll be happy to go into them. Meaningful use stage 1 only meant you had to be able to exchange the information, not that you actually had to exchange it. Moving into meaningful use, now there's some certification requirements that actually require that you send a certain percentage of your laboratory test to another entity using the standard terminology LOINC. Great. We have, depending on what study you look at, 80 to 90% of our healthcare institutions have instituted electronic medical records, now known as EHRs because they're more comprehensive. And we're collecting all of this great clinical data from this meaningful use regulation. I think probably most of us in this room are now aware of things like social determinants of health, genomic data. We are actually starting to see in some of the payment structures where providers can provide food for their patients, or they can provide housing for their patients because of quality of care programs. So payers are giving a certain capitated amount for caring for their patients to the providers, and they can do whatever they need to do for that patient, including providing food and transportation to physicians' offices. So social determinants are becoming more and more important. The key takeaway here is that we have to be able to use all of this data in order to really analyze it, in order to be able to use it and get the meaning out of it that we really desire for better care, lowering the cost of healthcare. Okay, so how does the data come to us? Several different formats. Structured is the easiest to use. It's going to be that claims data that we talked about. You know what it's telling you. You know where it comes from. You have a date stamp on it usually. It's codified. When I say structured data, I'm really talking about codified data. So those are your ICD-10 codes. They could also be a medication list that's codified to ARC's norm, or a problem list that's codified to SNOMED. Very structured, discrete data elements codified to a standard or reference data that is then usable across your institution for all of your use cases. Semi-structured, we're getting more into that clinical data. A lot of the stuff in the EHRs today is not codified to standards. So it's going to have a semantic tag. It's going to have come from a order field in an EHR. So you're going to know that it's a laboratory order or a radiology order. But it may not be codified to a standard, and in fact, often is not. We have a couple of examples of that. We have one client that is a vendor that aggregates information from many providers in their area. They have over 100 different ways to say hemoglobin A1C. There are only 5 LOINC codes for hemoglobin A1C. Only 4 of them are used in the United States. There's no reason for that data to not be codified to LOINC. In order to use it, you're going to need to make sure it gets codified. Another fantastic example of that is same client aggregating data across providers, 500 ways to say aspirin, right? I'm seeing heads nod. You've seen this type of data. Again, you need to codify it to a standard, generally ARC's norm for medications. And then finally, we have the unstructured data. We'd like to say in healthcare, we have about 80% of our clinical data is in unstructured text, but it's rich, rich clinical information. It is the physician's notes, their observations about the patients. It's PDF files coming from pathology reports or radiology reports. It's nursing notes. It tells the patient story in ways that structured and semi-structured data cannot. And we have to be able to extract value out of that as well through advanced analytics, through natural language processing and AI techniques. Again, need to codify it to standards. Those standards are what we're going to talk about today, what I refer to as reference data in healthcare. So I'm sure most of you in this room, because you are at an analytics summit, are very familiar with the idea that the data that we have is really, it's only useful when we can turn it into wisdom. Once you go through this pyramid on the left from data to information, turning it into knowledge, making inferences and creating wisdom, now you've got value for your healthcare organization. There is only one way to get there, and that is through data governance. And I brought some papers up here because I do have a quote. One of the quotes from, this is the director of analytics at IBM. He's a physician. And he says, when you are waiting for results from a medical test like a cancer biopsy, that call from your doctor can't come fast enough. As a doctor, I am sometimes so buried in an avalanche of medical records that it can delay decisions about what to do next. It is exactly this situation, the sheer amount of information that we doctors deal with in our struggle to identify and act on the right information, that's causing more healthcare organizations to turn to big data and analytics. The problem is not that doctors and hospitals don't have enough information. It's that we have too much. It is our job of people in this room to turn that information into knowledge, present it at the point of care to those physicians so that that cancer patient can get their biopsy result quickly and either be rest assured that they're going to be fine or they get the treatment that they need so that they can be rest assured and be fine. That really, at the end of the day, is what we are trying to do with all of this data. Where does it exist? The answer is everywhere. It is in every system in your organization. It is in every department. It is in every chart, every claim, hopefully aggregated in a data warehouse, but not always. The reality is that data is locked in silos. And it is our job to unlock those silos so that we can have better communications with our patients, so that we can transmit information across systems and across organizations in order to make sense of it all. reference data management can help with that. There are a lot of questions yet to be answered. So I think we've probably talked enough already about where the data falls short. It's in silos, you can't access it. Big data is only meaningful when you can make sense of it. What we find across organizations, this cost duplication is probably the biggest area that we see problems across organizations. You have multiple departments sourcing reference data, so you've got duplication of licensing fees. Some of these reference terminologies carry some pretty hefty licensing fees with them. You don't want to be paying those fees twice. You don't want to be paying the same employees to download reference data, to manage the data, to extract the data. You don't want to be having duplication of your employee costs for managing all of that. And that's probably the biggest issue we see across organizations as we work with them. When you're sourcing departmentally, you're also probably doing it manually. Any kind of manually sourcing of this data is going to lead to errors and data quality issues. We have one client who has one person in their organization. It's a large organization, so at least they're doing it with one person, but she's doing it manually. And every time CPT updates, she goes out to the AMA website and she copies and she pastes, and she copies and she pastes, and she copies and she pastes. Well, that's great, but CPT updates 18 times a year, and the codes are effective maybe on March 1st, maybe on June 1st, and their descriptions are in different PDFs across the AMA website. So you have to make sense of all of that, get it downloaded into your spreadsheet, and move along your organization. The result of that manual process for them was 1,000 different procedure codes without a description in them. You don't want that at your organization. So what do we, oh, my favorite slide, forgot about this one. Here's some reasons why data governance matters. I don't know much about engineering, but I love the example of the Mars Climate Orbiter that disintegrated as it took off because the engineers used one system of measurement and the orbiter used a different system. The trajectory that was calculated by the engineers couldn't be interpreted by the orbiter, and it blew up when it took off. Your sending system and your receiving system have to be speaking the same language, and they have to understand when in healthcare, when a code was active and when it wasn't, and what it meant on a certain date. The second one, do we have anybody in here named Bob? I apologize if we do. This could be anybody in your organization, tribal knowledge. We're guilty of it sometimes in health language. I'm sure you all are guilty of it as well. You have one person who knows everything about a certain data set. And boy, if you have any question at all about how that's used in your organization or what it means, they can tell you. My favorite question there is, what happens when Bob wins the lottery? Probably not going to show up to work the next day, right? You don't want that. Even if Bob stays after he wins the lottery, do you really know what he's doing with the data? Do you know where he's getting it? Do you know who's using it? Do you know what it really means? Do you have data governance around it? Probably not. It's time for Bob to go and for you to get some automated processes and good best practices for data governance in place. So hopefully I've convinced you at this point that data governance is key to any kind of analytics or secondary use of data in healthcare. Anybody disagree with me on that? This is participatory. All right, no arguments. So Gartner in 2007 released this master data management framework. Most of the rest of the world is using it. Healthcare is finally catching up. What do I mean when I say master data management? I mean it is a philosophy, it is a strategy, it is a cultural norm to manage all of your data assets with a vision that starts at the highest of leadership levels and works its way through the organization. It is people, processes, and technology to manage your data so that you can get the best use out of everything that you're collecting to really affect the care of your patients and the efficiencies of your organization. At the bottom of it, I believe that reference data management is the cornerstone. That is not Gartner's idea. That is my organizations, but I do believe that reference data management is the cornerstone of a good master data management platform. So what do I mean when I say reference data management? Well, we've talked about the acquisition of reference data, CPT, ICD-9, HCPCS, LOINC, RxNorm, all of the different reference standards that we have in healthcare. There are over 200 of them. So don't ask me to name them all. I doubt that anybody in this room could name them all. There's a lot of them. Making sure that you have a single source of that reference data and you have standard processes and standard formats is key to a good reference data management solution. The second bubble there says list management. What I really mean is content authoring. Every organization has their own content. Sometimes it's as complex as an ontology. It is for a specialty care organization, the reference data may not exist and they have to create their own. Or it may be simply a list of locations in your hospital or departments at your organization. That's all reference data for your organization. It is also taking that standard reference data, CPT, ICD-9, HCPCS, and grouping it in meaningful ways. List management. We all need to cohort patients and understand different disease states. We use reference data to do that, and we group it in meaningful ways. The list management piece is what we're going to be doing most of our talk about today. And then finally, you need to make sure that this information, both the reference data that's put out by standards bodies and the content that you're authoring, is integrated and distributed throughout your organization so that everybody in your organization is using the same set of data at the same time. I'm going to dig a little bit deeper into each of those. My favorite topic, and I think you've probably picked up on this by far, is data acquisition. On the left, you've got just a sampling of some of the standards bodies. These are the key players probably in healthcare today. You've got CMS releasing ICD-10. They also release HCPCS, and they don't necessarily do it on a standard schedule. The AMA, anybody in here from the AMA? Oh, good.
Good, because I have some questions for you.
We'll talk later if you're from the US. So the AMA releases CPT. And I do have some statistics on the releases of CPT. I referred to it a little bit earlier. So the first release of codes for 2019 was in September of 2018. They had 129 new codes that they offered, 72 invalidated, and 269 codes had short, medium, or long-term changes. Great, simple. It came out in a data file. You can process it, update all your systems. You're good to go. Except in November, before you got all of your systems updated from that September release, they added 4 additional codes, all of them related to oncology services. So if you're doing oncology services, those 4 codes meant a lot. Hope you didn't miss them. Then just when you thought you were done, in January, the codes are effective now. So in January, they went ahead and released 21 new concepts, 20 of which were temporary codes. Those are fun. They made 12 additional short, medium, and long-term changes. If they were meaningful to your organization, let's hope you captured those in a timely manner to be able to incorporate in those lists and that content that you author. And let's not forget that in May, they put out 21 new codes, all about laboratory analysis. And it goes on and on and on like that all year long. It comes out in a PDF format, comes out in a data file, it comes out in 4 different PDFs. It's a mess. It's a nightmare to manage. And you don't want to be doing that in spreadsheets. Compound that with SNOMED International releasing twice a year. The National Library of Medicine then releases 2 US extensions to SNOMED, different times. LOINC, Registry releases LOINC twice a year, different times than SNOMED releases. And finally, you've got RxNorm being released weekly with Delta files because medications change daily. And then you have a monthly catch-up file for RxNorm. A nightmare to manage in a spreadsheet. Definitely need automation. I don't know if you can tell, this is sort of my passion right here. List management is the second pillar of reference data management. This is the content authoring we talked about. I'm not going to spend a lot of time on this because all of our use cases are around list management. But essentially, they're building blocks for any kind of analytics or secondary use of data. It's the way that you identify does a diabetic mean in your organization? What types of procedures do you allow for what types of disease processes? What is the best practice for laboratory testing for a certain disease or presumed disease? How do you confirm this, that, or the other diagnosis? These are all lists of codes. Cohort management, oftentimes it's called. So finally, in a good reference data management system, you need to make sure that all of this data that you're collecting, all of this data that you're authoring is integrated and distributed throughout your organization, feeds into a single source, usually your enterprise data warehouse, and feeds the rest of your systems. Again, I don't know if you can hear. This is what I live and breathe every day. It's critically important for interoperability. It's critically important for analytics, for any kind of machine learning or AI initiatives that you have going on. And I think that brings me back to Shannan. She's going to talk about how she implemented this at Blue Cross Blue Shield of Tennessee.
So are there any physicians in this room? Okay. Are either of you familiar with your new model for paying for CPT codes from the AMA? Do you know what you're being charged this year for your use of AMA, or you just do that to pass through your vendor, through your EMR vendor? Okay. And what about you? Do you know? No? Okay. I encourage you to ask your vendor how much your licensing fees went up.
It's a lot.
It's massive. For this first year for us, for my organization, it is 5 times higher than it was last year. Using the same model next year, it will be 23 or 26 times higher than last year. So they're getting more money from payers, they're going to get more money from physicians, and they're going to get more money from vendors. So really, I do encourage you to look. And I'm sorry, I know that's your professional organization, but ouch, that really hurts. So Cheryl mentioned earlier about Bob. I don't have a Bob in my organization. I have hundreds of Bobs with their own special silos. And so that's kind of where we fell short. We weren't short of data, but we were short of processes around how to manage that data. And so we had some quality issues that were significant enough that our COO told my now department, which was not then, that we needed to build an end-to-end governance program for the management of diagnosis and procedure codes. So basically, I got to write my own job description and create this really fun job that, people call me a disruptor at Blue Cross and a bull in a china shop, whatever. I don't care. I'm not really affected. So, but we had a problem of the downstream. So our department, the Coding and Reimbursement Research area, brings in the diagnosis and procedure codes, and we distribute them previously manually on a spreadsheet. So we bring in that file that we pay for, and we don't have to go to the website, but we have it all in a spreadsheet, in a data file that we copy and paste into our master data management file, otherwise known as an Excel spreadsheet with 95,000 rows. And so, because if you look at ICD or CPT, in ICD there's I think there's close to 90,000 codes now if you count the header codes, and we're managing that manually. And we did what our process was. We distributed to the organization, but not everyone was consistently taking and reviewing those. We didn't have a way to just categorize those in a manner that would let you look at it and what it means to your code list, or in other words, your configuration for the benefits for your self-funded group, so Nissan or Dollar General Store, or for Blue Care, the state of Tennessee, for MedAdvantage or whatever. So we were all doing that manually, and there was a quality issue significant enough that our CIO said, somebody needs to build this program, so it has to be you. So then I got hired and created a job description, and then we built this program. And what we had to do was take an organization that's been in Tennessee for a long time, and I'm working with people who have been there. A lot of people have been at Blue Cross Blue Shield for 35 years, and they have always done it this way. And that's how we do it. And so changing that across the enterprise, it's very difficult. You have to start with the buy-in from those people in the beginning. So we had several Kaizen events that our enterprise process improvement team led, and we kind of drew out what our current process was, and then we drew out future state if we leveraged those people, our processes, and this technology that we were purchasing, this tool. So leveraging people, processes, and systems, we went from a manual process to a very streamlined process. For one group, we were able to we took their process of 6 to 8 weeks, and we managed their codes in 45 minutes. We updated their list, and these were for ACA-directed preventive services. So we were able to decrease that time astronomically. So they loved us after they understood what we were doing. So we had service level agreements for claims processing. We need to do a certain percentage first pass. We need to do a certain percentage accurate the first time, not just pass it through the first time, but actually pay it accurately. So we were having some issues with some of those. So we were able to just take the after buy-in, and it did take multiple Kaizen events, because we had a dozen or so, maybe 15 processes where people were updating their codes when they came in. We reduced that down to 3 main streams. So now we have standardized processes, and it'd be great if we could say we had one process that was standard, and we have a standard base, but truly we do have variables that kind of force us. You know, some of it is for clinical management, some of it is for analytics, you know, so we can't just have the one, but streamlining it down from a dozen to 3 helped us significantly. Let's see, we broke down silos because we had this collaboration. Breaking those down, the first step to that was having that Kaizen event early and getting their input, and them telling us, we will not do that. And me saying, then what is your solution? How do we make this happen without you having to be the sole person responsible for this? And so we don't have one person owning the whole process, but we were able to identify owners of those particular code groups and say, when there are code groups, when there are new codes that impact your group of codes, you are the person who is required to kick off this process. And then my team follows that and does QA on that, which was an added after. This is one of the PDCA. I mean, we realized we weren't really following that. We weren't checking to see if everyone was doing what they were supposed to be doing all the way through. So now my team monitors that, and we reach out to the teams who may or may not have completed their tasks by the time they were supposed to complete their tasks. So this helps us to know with certainty that the codes that we have on a code group for a particular configuration, we can say to the requester of analytics for that particular service, for that provider, or for that group, we can say with certainty, this is what your utilization was over this period of time for this kind of service. And we know this because we have all of the codes updated to current, to what is effective today, and we can tell you that you paid X amount, or you allowed or disallowed. Sometimes it's disallowed. We have configuration that says do not pay if this is the case. So we can say how many claims have hit that service, so they can determine if they want to start adding new benefits for their employees. So the validity of this governance, what it does to the validity is astronomical for our patient care management for our members, but it's also so important to our business and our bottom line, as well as those we serve. And Cheryl has a use case to share.
I do, but before we go into this use case, are there questions for Shannan about what she was able to do at Blue Cross Blue Shield of Tennessee?
Okay, so she asked how I got the buy-in from the Bobs, and was that through the Kaizen events? And initially, I did a lot of name dropping. Initially, I said, Scott Pierce said to do this. He's our COO. So I was like, Scott said to do this, so you kind of have to. After we started the process and they realized I really did want their input. I had to say in these Kaizen events multiple times, I do not want to make this decision by myself. I don't know what is right for your area or what this causes you if you don't tell us. And if you have a different solution that is more effective or more efficient, then tell us, and we're happy, let's make it work. So a lot of it was initially name dropping of the COO, and then afterwards it was the Kaizens and the constant collaboration. Mm-hmm.
So the owners for each code set, what system do you have for having them verify and test?
Okay, so we use a product from Wolters Kluwer from Health Language, which is a subsidiary, and it's called Code Group Manager. And so what we do is we build these code groups in that tool. It's cloud-based, and when a governing body publishes an update, I'm sorry, I didn't repeat that question, did I?
You did not?
Let me repeat the question. His question was, what system do we use to manage those updates? So in the background of that, the coders, the diagnosis and procedure coders in our organization build these code groups in that tool. And you have to build it with a specific, you have to understand coding and build it with algorithmically so that when that update happens, the language engine will run a protocol in the background and query all of those lists using AI.
Right.
And so when it'll come back and say, hey, owner, Bob, whichever Bob you are, you have new codes that impacted your code group, so you need to go and review those. As administrator of the system, I get an impact report, so I know every code group that has potential impact. So we track those. We track those through to make sure that they have been reviewed and a decision has been made in time for our configuration group to put it into configuration by the effective date of the code. It's a pretty cool system. Any other questions right now? Okay.
Okay, thank you. So this use case is another one of our clients. It's a vendor client that services the primary care market, specifically in rural areas. And the problem that they're trying to solve is access to specialized care. As you can imagine, I'm sure anybody here been referred to a specialist and had to wait 3 months to get an appointment? Right? It happens all the time. And that's in a major metropolitan area. If you live in a rural area, you may have to drive 3 hours, 6 hours. You may have to stay overnight to get that specialized care. You may or may not have the resources to do that. You may not be able to get the transportation needed. You may not be able to take the time off work. As a result, people are not getting the services they need from specialty care. And the goal of this particular client is to connect primary care providers with specialists in order to be able to come up with a plan of care for that particular patient that the primary care physician can administer, right? It's an electronic system that allows a primary care physician in real time through telehealth type mechanisms or asynchronously through email and notifications. They can get consultation from a specialist in order to make sure their patients are taken care of. Really, really great idea. As you can imagine, they have to build lists of codes in order to do this. This diagnosis, I need these tests. This particular diagnosis, I need to understand what the treatments might be available. These are all lists of codes using reference data. Some of it, the billing and coding that we're all familiar with, and some of it, much of it, is done in LOINC. LOINC is the reference data that's used to manage observations, whether it be laboratory, radiology, or sometimes summary clinical observations is managed through LOINC. In order to build these lists, I think Shannan referred to algorithms that we use within the Code Group Manager tool that she mentioned. You have to understand how LOINC is composed, and you need to understand clinically what these tests are doing in order to build these lists in a meaningful way. They didn't have clinicians on staff, they had technologists on staff. So what they needed was consultation from a clinical perspective and a terminology perspective, as well as a tool to manage these lists. So what did we do with them? well, they first identified what were those high-impact diagnoses that they wanted to connect primary care physicians with specialists first. One of those examples is primary hypertension. So they had some checklists put together of the tests that needed to be done in order to talk to a specialist and get consultation around primary hypertension. This is just a list of some of those tests. It's not all of them, but it's some of them. Multiple LOINC codes for any one of those tests, particularly when you're talking about liver function tests. What is a liver function test? I think there were 2 physicians in the room. What does that mean? Right? It can mean a couple of different things. You need to understand what type of liver function tests, what are the specific tests that are done in that particular panel. So we help to identify all of that for this particular client. And as you identified the ANA test, you can then utilize it across different checklists. There are multiple different diseases that you might want to perform an ANA test for. Once you've created that code group, now you can associate it to your different diagnoses. And really what they're trying to avoid is they're trying to connect specialty care. They're trying to avoid ED visits. They're trying to avoid inpatient hospitalizations. Through this project and through creating these code groups and connecting your specialty care with your primary care, they had some really impressive outcomes. More than 70% of what would have been a referral to a specialist that may or may not have been followed up with could be handled through these virtual consults, connecting the primary care with the specialist. Really impressive, especially in a rural healthcare situation. They decreased the emergency department visits by 11 to 12%, and they increased patient satisfaction and access to care. Who can argue with that kind of an outcome? It was the same processes, the same ideas that Shannan talked about. You have to get buy-in. You have to make sure you bring in all of your stakeholders in order to understand what are these tests that need to be done and what referrals are important. The outcomes can be pretty significant across the healthcare spectrum.
So I have a question, because I'm not so familiar with that use case, because it's not in my organization. So this sounds like you've taken like a standard protocol from an EMR, like here's a diagnosis, here's a typical order, like here's our standard order for this, and added the referral management to that kind of management.
Correct.
That's pretty cool.
Other questions? Okay. This is probably my favorite use case, and I can't wait to hear Shannan talk about what she's doing with all that sensitive data.
This is actually my favorite use case too, because it's the one I'm working on right now, so I'm loving it. So I mentioned earlier SAMHSA and substance abuse and HIPAA and federal regulations and how they kind of conflict. And, you know, the industry has been handling this kind of data for a long time. Way before electronic health records, there were rules against releasing information that were considered sensitive diagnoses. And it was only diagnoses before. It did not talk about the lab tests and things for a while initially. And so we did that in the paper world. Well, it was easily managed because we had a legal medical record and we could actually look at the paper and we knew what pieces of paper we could send and what we couldn't. From a legal medical record perspective, we can't do that so much with the electronic medical record, because what is a legal medical record? There's really no clear definition of legal medical record in the electronic world. Nobody has a really complete definition of what that is. In the paper world, the legal medical record was on the right, and any other documents like living will and things like that would be on the left. Like it was just to open a folder and you know which side it was on. Here, it's in so many systems and so many pieces, even within one system, that it's not real easy to define. So we've always done a great job of suppressing information that we shouldn't be sending. The problem is now with the legislation that we spoke of earlier from the ONC and CMS, now we have to worry about information blocking. So how do we release the information that we're required to release for HIPAA, but not violate the substance abuse? And if we are trying to be HIPAA compliant, and it comes from a Part 2 provider, then are we at risk for information blocking? What is it that we are, the goal is to be able to share clinical information with providers for those members so that they can get the complete care, so the provider sees that full picture. I mean, it's important, I'm not a physician, but it's important, I believe, if you're treating a person physically, that there are some categorized mental health conditions. Substance abuse is categorized as a mental health condition. Those are important to the physical treatment of your patient. And so what can we release that is helping you manage the care of that patient without violating their privacy, according to at least two pieces of conflicting legislation. So we had this, I think because we built the data governance end-to-end for just general diagnosis and procedure code updates, I was invited to participate in 3 different work groups, committees, councils, whatever. I think it's a work group, a committee, and a council. And the work group is a sensitive code work group. And so the sensitive codes are actually created by my vendor, and they are based on, they're categorical for the federal regs, and then there are substance abuse and mental health that are based on the SAMHSA regulations. And so federal, and they're both federal, but then you have state-specific laws or regs that are sometimes more stringent than the federal. So we have to, being a payer, we may be hosting claims for people from all 50 states. So we have to consider how do we determine what is appropriate for the members who have, Blue Cross Blue Shield of Rhode Island. How do we know what their regulations are? So this work group is actually, we're doing very stringent suppression at this point, but we're looking at this globally, or at least all 50 states and probably Puerto Rico. Our legal team is doing a matrix. So this work group involves legal. It involves us coding and reimbursement research. It involves the medical informatics and information delivery teams. And we report up to the C-level, senior VP and up, for what our plan is on how we're going to mitigate the risks of this. So right now, the legal team is working on a matrix and they're focusing on HIPAA because SAMHSA, everything that's Part 2 is suppressed unless the member themselves asks for it. But for HIPAA, we have to make sure we're not going to violate all of any other state's laws. So we're working on a matrix that says every state, if they have any regulation at all related to privacy beyond the federal, and then is it more stringent or less stringent? Florida, California, New York, they have some very specific and very detailed legislation on what you can release, what's considered sensitive, what you can release and cannot. I did hear at one time a health plan in Florida turned off their gender edits for their claims because of the population there that is non-gender. They don't identify as a specific gender, or maybe they were born one gender and then transformed to another. So they turned off some of their edits because they were missing those first pass, and they were not getting their service level agreements because of their population. So there's going to be a lot of manual review with that. So what happens is currently legal works on that. The technical team and myself are working on what are we suppressing that we shouldn't? How do we identify Part 2 providers? Because Part 2 providers are not a license. If I had a provider number, it said I am a Part 2 provider, that would be super easy. But that's not how it is. If you take federal dollars, so Medicare, Medicaid, if you take federal dollars and you have a treatment, like a clinic or even a program that is for any of those mental health or substance abuse conditions, you are a Part 2 provider. So we don't know how to identify those because we get diagnoses that are part of that patient's clinical history that may be a current condition, but maybe you don't have a program. Maybe you're just giving, I don't know, well, do you give Wellbutrin for depression? Whatever a med is for depression, maybe that person has situational depression, just a short-term grief. So that's not Part 2. So can we suppress all of those mental health diagnoses? We absolutely cannot. We absolutely cannot because of TPO. Clinicians need to know that information. So we're working currently just to make sure we're not over-suppressing and to make sure that our systems can handle different logic. And, how do we build that in different logic? And then the final, not the final piece of this, but a foundational piece of this that we're working on, but it's more difficult, is identifying every system in our organization that houses any of those reference data. And it has ICD-9, ICD-10, CPT, HCPCS, LOINC, SNOMED, and RxNorm. So 7 reference data systems are in those sensitive code groups and categorized in that way. And we have hundreds of applications. So we're actually working with our team of enterprise architectures who have this new really cool tool, I think from maybe IBM, it's iServer. And we are building a model in there so that we can find we can identify where all of those codes are used in which systems. We can build that model where there's a relationship so that anytime there's a change in one of those codes that need to be updated in a system, we can go into iServer and send out a notification to say, here's a new code to put in your system for this. And we can use it. So it's going to be in conjunction with a tool we already have that we're using effectively and a tool that we're going to be that we're using. We're just learning how to use it. So, I mean, it's a complicated process, and it's technology and legislation and patient access and exchange. So we have to worry about the exchange part and the APIs and transactions. But so it's very complicated, and it takes all kinds of stakeholders in your organization to bring their skills and their expertise to the table. But it's really fun. It's really hard, though. This one is hard. So, any questions? Yes. So she had a couple of questions. The first question was, it sounds like we took data governance and applied it just to those specific code sets that we were charged with instead of, or did we make it organizational wide? And then the second one was, did we dictate to Bob that he was now the owner of this, or what was the option? Oh, the data stewards versus the business owner versus, so that's a lot of answers. There's a lot of answers there. So we did take one chunk and go with diagnosis and procedure codes to start our data governance, end-to-end data governance. We had to. I don't know any organization that can just build it all at once and cover everything. Have you ever heard of that?
No, even organizations that might purchase a data governance solution end-to-end with all code sets is going to bite off that elephant one chunk at a time and implement slowly.
Yeah, so we did for just those specific code sets that we were responsible for that was impacting the quality issue that we had. The plan, though, the goal, my goal, secret evil scheme, was that we would take that model and use it across the organization and build end-to-end, regardless of whether it's a diagnosis or procedure code, whatever reference data you're using, you can take my model that we built and you can apply it over here. You just plug in different systems and different reference data. The thing that people miss the most is exactly what you pointed out, is a data steward. So when enterprise architecture and medical informatics started talking to me, they said, here, look at this grid. I think we've got a governance program. I was like, okay. And they didn't. I mean, they thought they did because they don't understand. So a lot of people don't understand. It's not my employer, it's the industry. Unless you've been dealing with reference data for a long time in your career, you don't really understand the need for the data steward the way that it needs to be there. So what they showed me was a grid that had all the applications, and it had an IT owner listed and a business owner listed. So I said to them, what reference data is in each of these systems? And they said, well, I don't know. And I said, well, who's the owner of the data that's in each of these applications? And they said, well, I don't know. And I said, if you identify that, you're going to have a better shot at data governance because you don't know what you don't know. So with the model that we're building around these sensitive codes in iServer, that's part of that build, is to say, here are all the systems that have these types of reference data. And for each of those systems, there's a business owner, an IT owner, and those folks will have to identify a data steward for each of those elements so that we know they're the person in the process that gets the notification to update. That's a great question. I'm so glad you asked a data steward question. Nobody asked that. Did I answer your question effectively? Okay. Other questions? Yes? I can't hear you. I'm going to have to bring you the mic. Yeah, absolutely. So the question is about Trump's. I think that was an executive order, wasn't it? An executive order from Trump for payers and providers to be transparent about costs. What's it going to cost you to have a service, and what is your insurance company going to pay for that service? Yes, it definitely does apply. And in Tennessee, we actually have a Provider Stability Act, which providers ask for. And that Provider Stability Act says you have to provide a physician what you're going to pay them. You have to tell them what you're going to pay them for every service, and you can't change that reimbursement or the policy around the reimbursement without a 60 or a 90-day notice, respectively. So even without Trump's executive order, in Tennessee, health plans are having to do that already. So, and this absolutely does help with that. So we manage that. As part of the configuration, we have fee schedules. So the fee schedule will have like a CPT code or a HCPCS code, and then it'll have a fee related to it based on a CMS, RVRVU, or I don't want to get to the way they apply the cost and the payment and what a service is worth, what it's valued at. When those change, and we do say, I think critical access hospitals in Tennessee get 106% of Medicare. So if we were to change that for any reason, even if we were going to change it to 108% and give that provider an increase, we couldn't do that without that 60 or 90-day notice. And so we can manage it that way. Other questions? Yeah, okay. No worries. I believe, you can tell me if you think I'm wrong, I believe that reference data management is the foundation of the overall master data management. You agree with that?
I would totally agree with that.
So we are working toward true master data management. Now, every organization that I know of in healthcare will tell you they have a master data management program, but I've not seen one that's incomplete because they don't necessarily have that reference data management. So the elephant that I'm eating one bite at a time is leading me to that. When I've taken the last big ear of that elephant and consumed it, then I will have master data management, I believe.
That's fair. Did that answer the question? Okay.
Yeah, that's my philosophy. Do you have a different philosophy? Reference data is first, foundational, and then master data management is after. But Cheryl is way smarter than me, so I'm gonna let her answer that one.
I don't believe that for a moment, but when I think about master data management, it's less of a platform and a process than it is a strategy. Master data management encompasses all of the data in your organization, whether it's reference data or data that's created through your systems, your EHRs, your laboratory systems, your claims processing systems. Reference data management is all of it. I'm sorry, master data management is all of it. Reference data is the foundation that feeds it.
So my question is, if reference data is first, what would be the next set of data within the master data management?
So we're working on, in part of our master data management, we're working on email management. We also have a file net kind of thing where we have consumed medical records from providers for reporting to HEDIS or for, for STARS, for MedAdvantage, or for provider audit. Those are, that we have to manage that data. So how do we manage that data legally? How do we retain it for the amount of time it has to be there? And how do we destroy it? What is the destruction? So it's as easy, I mean, it's as foundational even as email. Like it can mean email, it can be an IM conversation. We do chat now with some of our members, and it can be those chat histories. All of that would be non-structured. It's not just the reference data that's codified. It's absolutely every kind of financial and business record that comes in to your organization.
So I think when you think back to that first slide where we talked about claims data, clinical data, and emerging data, if you were to have tackled the reference data, which is going to really feed that structured data elements, the claims data specifically, I think the next area that I would want to tackle is that clinical data, that rich clinical text, right? All of that information that's unstructured, similar to the emails, the chats, the telehealth, but it's really organizational specific. What's your next highest priority that's going to get you the biggest impact across your organization? Does that answer it better? Okay. Other questions? Yes, the question is around social determinants of health activities, a personal favorite topic of mine. There are codes out there to describe social determinants of health. They're found in ICD-10. They are found in LOINC, and they are found in SNOMED. Unfortunately, nobody uses them, and they're not robust enough. I know CMS is having conversation as we speak around ICD-10 codes for social determinants of health. There's a lot of work going on in this area, but none of it, and I'm sure you've seen this, none of it is really industry standard yet. We haven't identified what is the best code to identify that a patient is in a food desert, right? It's such a new area for us that yes, there are codes. They do exist in the standard data that we have today, but they're not being used, they're not being grouped, and they're not being acted upon in the way that they need to. I was very surprised when ICD-10 came out this year and there were no new social determinants of health codes. Fully expected to have several of them, and there were no new ones. So hopefully next year.
Yeah, and I'll piggyback on that. Starting a long time ago as a coder who was, combing through the medical record to pick up all the diagnoses, and there are rules. So even if a physician has if there's a lab, so a good example would be if there was some kind of bacteria that grew or some kind of organism that grew on a sputum culture, it's going to be that lab result's going to come back, or path result is going to come back, but that path report was not read by a physician, a qualified physician, diagnosis in a record. So if I code a pneumonia for my hospital that was an inpatient stay and it was 6 days, and I code simple pneumonia, that's going to pay for about 3 days, and it's going to pay you about $3,000 depending on your case mix. If you identify that culture and it was streptococcal pneumonia, you're going to get twice the reimbursement. But I have to query the physician to say, hey, I noticed there's an organism that grew on this culture that came back after discharge. Do you want to add any documentation to this record? And so that is all about financial health for your organization. But the rules are that even if the physician had this note, like just a written note in the HMP or in the discharge summary, if there's just a comment that says patient is homeless, I can't pick that up as a diagnosis code without querying the physician. If the physician adds that to the problem list or the discharge diagnoses, as a coder, I can pick that up. But physicians don't know that they have to put it there on that final discharge diagnoses for it to be picked up by a coder. Coding rules and guidelines could change related to that, and I hope that they do because there's a lot of social determinant rich information, modifying clinical factors that are not picked up in codified data because of the rules of coding and billing. But if we can pick up from those documentation elements there, then we would be able to identify that.
Really great question, and I hope to see a lot of progress in that arena. I know that we are well out of time. We're willing to absolutely stick around. We'll skip the rest of the slides, but take any additional questions, and we'll be happy to hang out and speak individually as well. Thank you so much for your participation today. It's been great.